to seek joy and kindness and mutual respect for one another. We seek to represent fairly and well those who have given us this task. Continue to remind us that all we do here today and all we accomplish is for the pursuit of truth, for the greater glory of you, and for the service of humanity. Guide our hearts and our mind in the spirit of fairness, right thought, and speech. For you are the source of all that is good. You are the source of all our blessings. Thank you for helping us to accomplish our work, our goal, and mission this day. We pray all these things in your holy name. Amen.
Amen. Sylvia, thank you very much. Please join me.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Again, welcome everyone. I have been advised there is no one wishing to address the board today, so we will move along to item number 4 on the agenda. To the board members, obviously the prior minutes from our prior meeting is attached and they're on the portal. If there's any discussion or any recommended changes, we would certainly address those now. If not, I'd entertain a motion of approval. Mr. Bose has a motion for approval. I have a second by Mr. Wynn. All those in favor say aye. Aye. Thank you all so very much. That brings us to the next item is, I guess, the board chair report. Last month, I think I was able to report on a bunch of activities I'd attended on behalf of this board. I think today, due to our time, I'd like to do 2 things. One is, most of you know that we had the fortunate situation that Dr. Simmons has joined our board. We approved him and he came on the board for the previous board meeting. He's got a long relationship with JPS, but I've actually noticed the announcement in the business press, Dr. Simmons, and so I just want to say welcome. At the first meeting, we had not really indicated which boards he would serve on. I've actually spoken with Steve, and we're going to appoint him to the Planning Committee and also to the Quality Committee. So thank you very much. And as everyone knows, on this board, there's 11 of us. We have a lot of meetings. Most all of our meetings are open, whether you're on the committee or not. Anyone on this board is certainly welcome and certainly encouraged to attend any of those meetings. So welcome again, Steve. The only thing else, Robert, again, for sake of time, I had the pleasure of being actually on July the 3rd. I was at the Tarrant County Commissioners Court. Their agenda's here. I had the pleasure of being there when Mr. G.K. Maness made a presentation, kind of an update presentation as where the proposed bond package or the bond consideration is on behalf of the Commissioners Court following the Blue Ribbon Committee report. So it's been a lot of meetings. So again, I appreciate Mr. Maness's leadership in that role. And I think during that meeting, there were some things that he asked us to look into. For sake of time, I think I'll kind of say that's my report, and I'll kind of move it straight to your report as CEO.
Thank you, Mr. Chairman. One comment I'd like to make before we start some of the issues that Mr. Powell discussed is I want to reach out to the physicians that I'm lucky enough to work with at JPS and the integrity that they have and the challenges that they face daily that a community would have no idea. If you're not a physician and you don't wake up to swinging doors trying to figure out how you save a life in 2 seconds, you haven't lived in their shoes at all. To deal with a patient who is psychotic or a patient that has a neuroses that causes them to hear things or see things that you and I do not see nor understand, and try to calm that person down and get them to take their medication, I just think it's time for this board and this organization to realize the incredible power that our physicians have and the appreciation that I personally have for physicians that come into this organization every day and deal with things that probably 90% of our population would not have an idea of, in a world that they live in the challenges that they face. And sometimes we expect our physicians to do things that just aren't in the realm of capability. So it is my thanks and my appreciation to our physicians. And I've seen so much from our physicians, from their involvement in JPS activities and their involvement in trying to make sure that this organization continues to run well. I couldn't be more proud of them. So I just want to take the time to thank people that make our world go around the way we want it to. Mr. Powell, what I wanted to discuss today is in comments to your mention of Mr. Manius, and we do have Mr. Manius in the audience today. And I appreciate him being here because I appreciate the county and the role that they play in our efforts to try to figure out how JPS can be the best to its taxpayers and be the best to its patients. And in that regard, when the Blue Ribbon Committee met and began to discuss things, and we had the luxury of having two current board members that served on that Blue Ribbon Committee, both in Dr. Simmons and Mr. Petty. They went through that process. I'll remind everybody here that the process of the Blue Ribbon Committee was not to assess a dollar amount. It was to determine need and wants and trying to figure out what the needs of JPS were and try to categorize those and begin to look at those and begin to put those and memorialize those on a piece of paper. What I thought we'd do today is have a bit of a discussion to sort of capsulize some of that and begin to look at the overall aspects of how you categorize that. And I think it's my responsibility and the responsibility of the administration here to help this board in its decision-making process and give you guidance and give you suggestions for somebody who's here every day trying to figure out what we do to help you all as you come in and make the policy and procedure decisions as we go forward. So as you look at the Blue Ribbon Committee comments and their suggestions on what we do, what we thought we might do is have a discussion today and look at some of those items, but not look at those items one by one or go through and prioritize each one. That's a difficult task. But I wanted to start by telling you that it is the administration's view, and I do think the view of this board, that a high priority be given to mental health and its mental health needs. What we're seeing in today's society, for whatever reason, and there are a lot of scholars that can tell you why or suggest why, the incidence of mental health issues are challenging for our community, and they seem to be on the rise. And it's not just the nature of somebody reporting something that, quote, wasn't reported before. It's just the rise of challenges that people face in the world in which we live in. JPS, not to remind y'all, but to tell the community and some who are in the audience, and Mr. Kennedy, thank you for being here today as a reporter. I want to make sure that the community at large understands that JPS is the only psychiatric emergency room in this county. Now, that comes with a great deal of responsibility. And the major part of that responsibility is there's nobody that provides higher care at all levels for mental health than JPS. To that noble cause comes the issue that you don't and cannot turn anybody away. People show up at our door, and oftentimes show up at our door, and we do not know if they are a medical emergency or a psychiatric emergency. So when they come through an emergency room that's already seeing 850 people a day, or they find their way to the 10th floor in our psychiatric emergency room, there is a significant need for JPS to give to this community what it needs. And what it needs is a strong mental health foundation and growth. And our population is growing. I will mention to you that because we cannot turn people away, we find ourselves in a situation of when our beds are full, and they oftentimes are full, we have 96 of them, and when they are full, we then have to go to a third party to take those patients. We don't shut our doors and say, go somewhere else. We have to find where those patients go, and it becomes even more problematic finding private facilities that want to take a patient that has no source of funding. So we pay for those patients in those places, and it's not a bargaining chip. We don't show up and say, hey, what kind of deal do you have today? And there aren't specials that we found. It's not a 2-for-1 sale at any time. It's a challenge. So we end up paying a large amount of money to help those patients find care when JPS is full. The other challenge that's compounded by that is because those facilities do not want to deal with patients that have a non-funding source, JPS has a disproportionate amount of folks who unfortunately have no funding stream, and those that have a funding stream or a slight funding stream sometimes are accepted. So oftentimes, our colleagues in the industry will say, sorry, we can't take your patients. You're the place where the acuity level is the highest, you take the patient, we won't take that patient. And it's hard and it's a challenge for us. The other challenge we have is those individuals who are elderly and are facing dementia and facing other problems. When they become disruptive in the healthcare setting that they're in, they will oftentimes be brought to our emergency room. So I wanted to lay that out to you to say that the Blue Ribbon Committee and what it represents has an emphasis on mental health. And it's my opinion, and it's the opinion of this administration, and I would venture to say a significant portion of the people, if not all the folks that work day in and day out at JPS, that our emphasis needs to be on mental health. It's an area that no one can pick up that slack but JPS. So when you look at the Blue Ribbon Committee, you look at mental health and what its needs are. The challenge that we will have, bond package or no bond package, if the commissioners call a bond package and it passes, we still have a time lag by which those structures have to be built. So we want to be agile and nimble to see, even in the midst of that, if there are answers, if there are anything else that we can possibly do, and try to attempt to look at some form of revenue streams too to offset that disproportionate amount of folks who seek and need our help who don't have the financial means to deal with it. You have to have a balance. If not, you can't take care of any population. So when you look at the Blue Ribbon Committee, and if somebody to say, well, what's your emphasis? My suggestion to you all as a board and my suggestion to the community, our emphasis is definitely going to be and should be mental health. If you all think differently, that's certainly of discussion, but my recommendation to you is to strongly look at the mental health component. The other thing about mental health, it is totally non-discriminatory. It doesn't look at anybody's wallet, and it doesn't look at anybody's height or width or color. It just affects, and it's a challenge. So as we go through that process, remember that it is an unfortunate, non-discriminating, it will affect anybody, anytime. So as we go through that, that's where our emphasis is. To look into a second category and look at what the Blue Ribbon Committee said, it's to look at the issues of how do we predict the future, the next 5 years, the next 10 years. And one of the things that is becoming ever more clear to us is acuity models and what we need to do to create a population health model that is effective and a population health model that reaches out to our community in primary care so that we can deal with an ever-growing acuity issue that we're going to have here, such as your emergency room and the size of an emergency room and what you're going to do. Obviously, the best way to better health is to manage it up front as quick as we possibly can and as many times as we can. That oftentimes means access. If you make it hard and you make it difficult, if you have phones that don't answer, if you have clinics that aren't open, if you have clinics that can't be found, if you have providers that aren't there, then people are going to seek an emergency room. And your emergency room on behalf of the taxpayer is the most expensive, and it's going to be your most challenging form of care. It's going to be episodic care. It's not going to be long-term care. It's not going to be a care plan. It's going to be a fixed plan, an immediate fixed plan. So the second area that I think you all should look at when you looking at the value of the Blue Ribbon Committee and where we're going is their comments surrounding what we should do in the community and how we look at our acuity levels and how we look at creating a primary care basis. The third category comes in the area of what you do here at this facility. We have acute care. We are a level 1 trauma center. Again, we are the only level 1 trauma center, and we're going to get the toughest of the tough cases oftentimes, and we're going to get the cases that sometimes have the most levels of complication. So in that, we're going to not only need an effective trauma center, which we have, but you're going to have to also have beds for those trauma patients to go to. And when you have the emergency room, the size of the emergency room we have, you got to deal with, once you triage those patients, getting the rooms for them. So we do have to address our current structure. I'll remind everybody, and you know this well, is we have not seen major changes here and not had a bond package since 1985. It's not woe is us, it's just to say that that's tough in your upkeep. It's tough in all the aspects of your maintenance, your facility that you have. That's difficult. Plus, healthcare's changed a lot since 1985. It's changed a lot since 2014. And in that regard, we have to be up to speed or we misrepresent the public. Bottom line for y'all that I would recommend as we look through the Blue Ribbon Committee is you have two major loyalties. We have a guiding principle that says how effective can we be for our taxpayers and wisely spend their money. And we have a loyalty and an obligation to our patients. Patients who can go anywhere they want to, and patients who find themselves not being able to go other than to JPS. But we have an obligation to all those patients who come to the front door at JPS. So I thought maybe we'd have a bit of a discussion about that or anything that you all want to say. I want to thank Mr. Petty because what we would like to do is, since we are all gathered, it sounds like the beginning of one of your prayers, and it may well be. But since we are all gathered, it might give us the opportunity to have some of those discussions here today, but then ask Mr. Petty and a few others to begin to look at some of those. What I don't think the court is asking us to do, in my interpretation, is go through the Blue Ribbon Committee and rank them 1 through 35. I think that is not only an impossible task, but I do think what the court wants us to do is say, if we call a bond election, what are the parameters? What JPS do you think you really need as we look at this? So if this is a bond package of X amount of dollars, or is it a bond package of Y amount of dollars? What is that amount that we think we need? And any guidance that we give the court, I think, will be helpful. So, Mr. Chair, if there are questions or there are comments, the other portion of this that will come after this will be the aspects of what does JPS contribute to this? What can we do to help the bond package? What do we do to stimulate that bond package? And as you know, we've created a future fund. And Sharon, correct me if I'm wrong, but currently today, $117 million in that future fund. So we need to begin to ask ourselves the question, how do we do, or do we do more? And if we do more, how do we do that? The court has begun to fairly look at our days cash on hand and ask the question of us, is that the proper amount of days cash on hand? Do you want to lower that and create a little bit more money or possibilities? The last thing I will tell you, and I've had the counsel of Mr. Manius, and I've had the counsel of third-party bond experts. This all doesn't have to be issued at one time. So I don't want you all as a board to think if we have a bond package that we've got an X amount of bill each month for a bond package, and nobody knows that better than Trent Petty and what the work you've done. So this can be over time. So we need to figure out how we do that and how we help the court. And then I'll be quiet with the last statement. The court, in my opinion, five county officials are supportive of JPS and trying to figure out what we do that's right. We need to help them, and they need to help us. This is a real process of partnership. As we go through this, they have a concern, rightly so, for the elected positions they're in. We have a concern for the 1.2 million patient encounters we have and running an operation the size of this and keeping it going. You got an operation side, you got a patient side. So to that means, I think we can do that. So that's kind of what I wanted to have a little bit of a discussion about today. Is that fair, Mr. Petty? Is that outline fair?
That's great. And just as Chair of Planning, Chair of Planning, and I'll also defer to Dr. Simmons, who, again, sat with me on Blue Ribbon. I think Robert's actually accurately characterized this. Blue Ribbon really didn't go through that report and say, well, let's not do any of this. They said, let's do all of this. As a matter of fact, that list even became more comprehensive by virtue of Blue Ribbon. There was a very sincere recognition of the need to expand our primary care arms at JPS into the community. There was significant discussion about clinics. There was a great deal of discussion about the obvious, the elephant in the room, which is Robert has talked about in terms of our ability to take care of our psych patients. I think what we as a board have always tried to do since long before Blue Ribbon, long before any of these discussions were, let's focus on what the needs of our patients are, and let's defer to the people that take care of our patients every day to understand really how those needs best get met. And I'm still at that place today. I feel like from planning standpoint, this goes all the way through Steve and Ralph and Charlie, you, all of us that have had the pleasure of chairing this board have been facing this exact same issue now. This has been going on a very long time. And I salute the fact that the commissioners are now at a point where they're ready to call the election. I think JPS has and remains in a great position to do a lot to offset that cost. I think there's some incredibly important discussions that we have to have relative to the sustainability of JPS's operation and the outflow of capital that is accompanying a bond campaign. And I hope that today some of those questions that we do get around, because I know, and congratulations again to Sharon and the team for the recent AA bond rating. I mean, that's awesome. That speaks to JPS in a very positive way. We'd like to keep that. We'd like to be able to maintain that. So I think from planning standpoint, we want to look at certainly what those capital obligations are, where are they best spent, but also what about our operation needs to continue to be looked at. How do we continue to sustain the level of revenue that we have to sustain to treat our patients and to take care of our folks? Because if we get to a point where all we've done is focus on the immediate capital needs of the organization and haven't addressed what Robert's talking about in terms of diversifying revenue streams, for example, then we really haven't done everything we can do to support this bond election. So I think we have to be able to kick open the envelope a little bit and look beyond some of the things we've looked at in the past, things that in the past have been kind of off the table. You know, looking at diversification of revenue has not been something we've really spent much time doing over the last decade and a half. But I think that's one of the things we have to begin doing to be able to support this campaign. So I salute and appreciate the work of the staff in putting this together. Happy to, as chair of planning, to perform whatever role, Mr. Chairman, we need to fulfill to help forward it. But, and I'll defer to Dr. Simmons, Blue Ribbon clearly is exactly consistent with what JPS has wanted, and even more. And now it's a matter of understanding how we divide that capital and that operations in a way that best serves our patients.
Trent, thank you. And again, Dr. Simmons, thank you for obviously participating on the Blue Ribbon Committee. You know, the book's pretty substantial. It's been out on the website. It's out there for everyone to see. Like I say, there's 35 issues. I think we as a board, it's not an agenda item today, particularly for us to sit down, but certainly time is of the essence. So I spoke with Trent last night and also spoke with Steve, who chairs finance. And I think we'll be putting together, along with what staff's doing, along with Sharon, and what I would say, whether it's open discussion today and or start directing any questions you might have, and we'll get back at a meeting sometime in the not too distant future. But again, it's not an item, you know, obviously we all attended on February the 27th, the joint meeting with the commissioners, this board and the commissioners court. Y'all have got your reports, but now it's kind of time to know how we're going to bundle this up on a priority. So we're not asking you today to say, let's vote on this one is number 2, number 3. I think Robert's given us a pretty good summary of what staff recommendations are. But as a board, there may be some others. Dorothy, I think you have a question.
I support the psych service, and I know we're going to have the ER growth. And what I'd like to see us do as we go through this planning process is we can't keep just building larger and larger things. What processes will be changed that we can do differently? I mean, a lot of psych is not on-site. They're doing telemedicine and all of that. So I would like to see what that approach is and include that. I think adding some community centers is one of the things they recommend, and I believe that part of that discussion would be if we could do that without it being a part of the bond, and I would think that would be something else. On the hospital site, I just know we need more beds, and I think that's a critical piece. And I don't know if you mentioned it on this, but I'm still concerned that I still have that group sitting on the second floor, and that's not efficient for patient care, and make sure that we include that. I mean, it can be part of the primary care, but I think that we need to look at making sure that we have a better way, a more efficient way for those patients to be seen.
I think, Dorothy, you're exactly right, and I don't think we would do anything but that. When you get into the particulars of the granular nature, to move a second floor, to not make the mistakes that have been made here in the past, to have your ambulatory, most compromised ambulatory patients finding their way to the second floor doesn't make, orthopedic, does not make any sense. The other thing that doesn't make sense, obviously, is having a 10th floor where you have an intake for your psychiatric emergency. So those are mistakes in the past. I mean, you call them what they are. They're mistakes of the past that this team doesn't need to make. And for whatever reason they were put there, I don't know, because none of those records seem to be able to be found as to why they did. But we're not going to do that again. And your point's well taken. The other thing that you mentioned, which is even more granular, is the aspects of figuring out what role telemedicine plays. I think if we had had this discussion 30 years ago, it would have been significantly different, not just because of the technology, but because of our concept of putting a sick patient in a bed and healing them and then letting them leave. The process now, which appears to be documented by medical evidence, is a shorter stay in an acute care facility, and how do you get back to the facility at which is either your home or another facility outside of this area. So I think telemedicine, not only in the care for an average patient, but certainly the care for those patients who have transportational challenges, such as an elder population. When you're the caregiver at 82 years old for your 89-year-old spouse, getting people in a car and driving down I-30 and getting here or wherever you go is a challenge. So, Ms. DeBose, your points are not misrepresented, nor would they be misguided. They would be part of any plan. Dr. Simmons, do you feel that the description of sort of looking at those buckets and the priorities and all, and again, you could have 75 priorities, but is it explained properly as we begin to sort of look at this and help the court decide those? Is that a fair statement?
I believe it is. I mean, obviously the need is great. There are a lot of areas of need. One interesting thing about the Blue Ribbon Committee, I would say, is it was a very diverse group of individuals from all walks of life, political backgrounds, religious affiliations, and everyone pretty much came up with the same conclusions. The mental health was a very high priority on that, one of the top. And all the members of the Blue Ribbon Committee came to JPS, toured these facilities, talked with the people there, saw the patients. They were here on site several times as part of their assessments. So the mental health really stood out, I think, with the entire committee. As well, there's several other areas of need, the community outreach, like you were saying, but I think what you're portraying is very accurate from what the thoughts of the Blue Ribbon Committee were.
Okay, thank you. I appreciate that, because I know you spent your time and dedicated a great deal of your efforts to that, and that helped. You and Mr. Petty helped, and so did Dr. Lowry make that report the way that it is, and I appreciate those efforts.
Any other comments? Oh, sorry, Ralph, go ahead, I'm sorry.
Mr. Chair, I think we do need kind of a sit down, lay it all out on the table where our head and our thinking is in reference to this. There is a sense of feeling in the community. Well, let me rephrase that. Basically, where I serve and walk, the feeling is that there's a great need for a new bed tower. Is when you ask taxpayers to fork over dollars, and our facilities are nowhere in comparison to what they're building in this county. And I do know that there is major need for the behavioral side also. But as we look at it, and something Dorothy mentioned, I think is really key, there are developing and some existing now services that are taking place in the community, I think that we could partner with to help strengthen the neighborhood health centers or create neighborhood health centers. I was at a program not too long ago where they were trying to talk to us about a program. And so I think that I would hope we look at what has been marketed so far. And I think where we jumped out is that when we talked about bond program, the first thought was a new bed tower. And that got individuals excited in the community. And so now we push that back. I would ask us to be careful of how that affects the thinking and the vote.
Sure.
Good points, Ralph.
I just want to throw it out, but I think we just need to walk that through.
Those are all good points. Again, we want to be transparent. We were asked by the Commissioners Court to, again, kind of look at prioritizing things. I know they're looking at certain timelines as Mr. Main has presented to them at the Commissioners Court. So Trent, with your leadership, maybe we get back with everyone. We just want everyone to be thinking. I mean, obviously, it's a big report. I don't think we need the whole 35, but like you say, Ralph, we all come from different areas of the community, and we want to make sure we adhere to the recommendations here. At the same time, the Commissioners Court was kind enough to ask us to prioritize, so Robert, with staff and maybe under Trent's leadership and planning, we get back with the individual board meetings. Y'all be thinking about it because we probably will have to move and get some ideas, but perfect example, Ralph, you may have a different feel in 5 or 6 major things than someone else. We then come back together, Trent, maybe kind of prioritize those things. I think they're all great points, as Dr. Simmons said, but I think we've been asked to kind of prioritize them. Yes,
No.
I'm sorry. Go ahead, Ralph.
Yeah, Mr. Chair, I would like to ask with the CEOs, okay, is that there's a recommendation from staff.
Good.
I think we need to hear it. They're on the firing line every day.
You bet.
And I think we need to hear what they see is that those needs and some kind of.
Sure.
Yeah, Ralph, I think that point's well made. I think Robert was kind of saying that his recommendations are, i.e. not his, or staff, what they're here every day dealing with those issues. I think you pointed well
The one
made.
thing, before Mr. Norrie makes a comment, I would, Pastor, speak to an issue that you raised, which I think is critically important. And I have begun to reach out to our community colleagues in this. This is a discussion of JPS bond package, but this is a discussion about the health care for Tarrant County. And the health care of Tarrant County is not myopic to JPS. The health care of Tarrant County needs to be a cooperative effort between our colleagues at THR and at Baylor and at HCA and the facilities in Methodist Mansfield, because we are all interlinked in that, particularly with the growth of this population, the growth of Tarrant County. When every Rotary speech there is, you hear about one of the fastest growing counties in the nation, and that's a plus, and that's wonderful. But to that, your infrastructure needs to be prepared to deal with that. And part of that infrastructure is going to THR, to Dorothy's point, with new models that you would not have had an opportunity to have a discussion about in the past, you will now. So is there room for us to share some of our responsibility and some of our work and some of our efforts and some of the models with our colleagues in town and look at things that we hadn't historically looked at? And I think that you have a conducive group in this town that understands that, because there were days at JPS not all too long ago when you had 21% leaving your emergency room because of JPS's shortcomings. And that's not what any of our colleagues should be faced with or see. And at the same time, our colleagues need to provide assistance and help to us as we grapple with that. Because what is our benefit is their benefit. This is not a competitive world and we're going to eke into their world at all. It is understanding that world, especially when we go to some of these facilities and we say, we don't have space, and they'll say, well, you have the highest acuity, you take care of them. That becomes a tough situation on behalf of the patient. So I'm sorry, Mr. Norrie, I didn't mean to.
Don't worry, go ahead.
No, fine. And I've said some similar things to this before, but I just want to say them again because that's what I do. This 200-bed proposal is based on a number of assumptions, including the idea we're planning for 2027, that we're growing at a set rate, that all rooms are private, and I was told that was against the law at a meeting we were all at some time ago. I've never heard that law cited. I was promised I'd be told what that law was, but I still haven't seen that. That we're carrying about a third of the need, and that this percentage is not going to change. We're not going to change so that we're taking care of more than a third, which seems weird. Now, I understand we have to make assumptions to make planning, and so we can't say because these assumptions are not sure, we can't do anything. But I think that taking the assumptions that say make a huge outlay for a future need where it's likely to change is a bad idea. Robert's comments on telemedicine are right on point on this. Who knew that 5 years ago that today I could order small items. I can order toothpaste from Albertsons or somewhere, I'm not sure. Somebody at my house orders these things. And they arrive that evening at an unreasonably low price. It's unreasonable. I don't know how they do it, but it's happening. Uber is happening. But if you look at things that are more state-oriented, 100 years ago we had orphanages where we normally use foster care. What is that? That's a decentralization of the need being met in a more personal way. So things are going to change, and they're not going to change to be more centralized. They're going to be changed to be more decentralized. Telemedicine is going to change the face of medicine, and we're going to talk about that more and more and more. But the nature of JPS is not to do telemedicine. Not that it's against it, but we're about putting a large number of physicians in one spot where we can take care of whatever need happens to be. That seems to be a drive toward centralization in a time and place where we are in history, where services want to be decentralized. I'd also mention, of course, if you're being taken care of here in your home, HIPAA issues are non-existent, right? Or essentially. So everybody has a private room. The other thing that we haven't talked about a lot, and I'm concerned about this, whenever we build highways, we talk about how long it will be before the highway is just as congested as it is now. So you're always fighting the congestion. So when you add capacity, you're saying, okay, it won't be this congested for another 2.5, 3 years. Whenever we look at a hospital or a facility like this, and we're going to build another 200 beds, what is the wait time now? And what do we expect it to change to when we build these 200 beds? And how long will it be before it's the same wait time that it is now? If we create, and this kind of service does create this kind of problem, where you create demand when you have the supply. And so if we're going to wind up just inviting people to come here from Waco because they can get good service, and not that I'm against people in Waco having good service, but this is Tarrant County, right? And so we need to be driven toward a size and shape that serves the people of Tarrant County. And it's a difficult balancing act, I think, to say we want a good service that's going to take care of the indigent of health of Tarrant County, but we're not going to encourage people from Mexico to come up here and get their babies born, right? We want them to do that where they are. And we want to have a service that takes care of the people who are paying the taxes here. So all these things are what bother me, and what I'm concerned with is we're going to build 200 beds. Everybody's going to say, this is all great, and then 6 months from now, we're going to have the same wait time now, and people will be screaming about how the infinite demand has not been met. And so, thank you.
Thank you, Warren. I think, again, Trent, I know you're over there making notes. I know how you are. Yeah, you're making notes. I think what you're hearing is what we're asking this board to do is, in a very short period of time, look at the report again. All of us have those things. You know, Ralph, your point's well made. Dorothy, your points. Warren, I mean, we're not just talking about bricks and sticks here. We also have to add in a financial piece in all fairness, the finance teams and you know, Steve just mentioned that Sharon and her team's been working on. I mean, there's efficiency ratios, there's operational cost. It's when do you bill, when do you staff? So there's a complete modeling being done at the same time we're talking about prioritizing. So I don't think our intent today is to say, here's our top 5, but in a very short period of time. So Trent, if you kind of take that leadership, get back with individuals, y'all be thinking about those top 5 or 6 things. I don't think, again, we have to have 35 things, but I think the Commissioners Court and I'm not about to put Mr. Manus on the spot, but I was directed by the Commissioners Court for us to at least get these prioritized items back to them in in a fairly quick period of time. And I think it's very positive they're reaching out to us. They're not telling us exactly. They're saying, here's the report. They've got a copy of the report. We talked about our individuals on this committee. So y'all be thinking about it. And Trent, you may want to send out something to have people start sending in something, and maybe we need to have a meeting going forward. I know Steve's working already on the financial side with the financial modeling. So I think, again, Robert, correct me, our intent today, and from what I received at the meeting of the Commissioners Court on the 3rd, was let's prioritize. And then, Robert, I think we need to spend a little bit of time also on that second issue that you mentioned on the days cash on hand, on how that may be handled through finance and through the staff also.
Yeah,
If
let
we
me
kind- Go ahead, Trent.
recommend something, Mr. Chairman. I mean, in terms of, I think, a workshop of sorts that planning maybe helps agendize with your help and with staff's help, but then make that a workshop that the entire board
Yes.
is invited to attend. I think the more of us that can be at that, the better.
Sure.
What I don't want to do is add the time of having to go through planning and then take another
Correct.
2 weeks to take it to the board. Let's all try to be there if we possibly can.
No, Trent, right on. As I mentioned, we've been calling joint.
Yeah.
If we go back and look at our minutes now, in probably the last several months, anticipating the bond package, whether we had finance last month, it's a joint meeting of board and finance. So we will definitely make sure, again, we're emphasizing, please, to have board members attend all these meetings. Perfect. So point well made. Is there anything else, Robert, you want to
Yeah,
do before we-
the other thing I would mention is we obviously have time sensitivities here in the sense that the court, if it is to call a bond package, needs to make up that decision, I believe, by August 20th. We need to give the clearest direction that we can possibly give to the court on those levels of how we would like to see those monies go. The other thing that we need to be aware of, and this is more a longer-term plan for JPS, but JPS needs to look at models that are currently different than what we have traditionally done. And Dorothy spoke a little bit to it, and others of y'all spoke to this before, but our supplemental funding from the federal government or the state government is always going to be in a situation, I think, in the future, that we're going to see declining numbers come out of that. And to Trent's point, that's nothing that we can particularly control. If the federal government looks at formula funding and it changes it in the midstream, we get sent a notice, and that's what you deal with. So it is a challenge for us to look at that. We will receive less supplemental funds from the federal government this year than we received last year. And we need to take that into consideration as we go forward, which then begs discussion points of partnerships that haven't been created before. How do we utilize the JPS land that it currently has? How do we partner with people in ways that we had not historically partnered with? What do we look at when we start talking about the development of the 6 acres that we own on Main Street, and how are we smart about doing that? Because our reliance on a government source for all of the, or a portion of our funding is always going to be in a nature that is challenging. So we want to make sure that we're beginning to look at ways to deal with that in the future. So when we look at days cash on hand, and we look at where we're going, and we look at those kind of things, there will be, we as an administration will pose to you things that have not been traditional for JPS. But they will also be posed to you in light of the community in which we live in. And it will be in what we have available to us with our partners, both in healthcare and outside of healthcare. So as we move forward, I think you will see some recommendations from the administration. Now, those do not necessarily come in the next 2 to 3 weeks. It will come over time as we put those together. And some of the aspects of potential joint ventures or operating agreements that we have with others will be a different model for us. But I think it is time, to Warren's point, to obviously look at the world that presents itself to us. And that's what we want to try to figure out how to do. So we will move forward with that as we go, and when we begin to look at what we bring to the table and how we help the Commissioners Court. Mr. Manius, I think you can tell the court that we are here as their partners, and we are here to try to figure out how to make this work. And we come into that discussion, just as y'all, but we come into that discussion with an emphasis, obviously, on our daily operations and the patients who use them, and figuring out how to do that. Thank you.
Thank you, GK.
Mr.
Yes.
Chairman, do you think that some level of discussion needs to take place as we do budget review, as we go into the budget? Or if Finance Committee meets, maybe there's a supplemental report from Finance Committee as we talk about dollars and cents going forward?
Steve, I'll let you answer that. I know we have we have a kind of a timeline.
Right.
You know, Sheridan and her staff may just fall between what's going on with all the numbers we're getting, obviously, for the Commissioners Court. As you all know, we're also facing, by statute, a timeline for when our budget's got to be presented. So there's a lot of numbers being around, but go ahead. I know you're having
right.
several
And
meetings.
Reverend's right. I mean, I think
DT, I know you've been attending
the
several
timing of
meetings.
it's going to be interesting, because if there is a bond election, we won't know until November, and then, it takes a while for those things. So how much it impacts the next fiscal year budget, smarter people than I can tell us, but certainly we need to think about that.
I will tell you, Pastor, that there are rules and guidelines that apply to our residents for how much time they get off so they can get a meal in, how much time they get for sleeping. Those do not apply to the staff, and so our staff realizes that. So what we're doing right now is a couple things. One, we're meeting a great deal and changing our agendas and our schedules to sit down and say, what are the areas that JPS can look at to be more efficient at? What are the areas that JPS can look at where there is a cooperative or a collaborative effort with the community? And where do we go from the maintenance and operation? To that point is, you don't want to build a building if you can't structure that building with the personnel as needed, and we need to be upfront in understanding that for all, so that we have a level that people will understand what are those needs that go with that building and the care that come with it. Not the care of the building, the care of the people that get their care in the services there. So we're spending a great deal of staff time now looking at JPS's efficiencies, productivity, and partnerships and collaboration. Yes, ma'am.
I agree, but I want us to also focus on how our IT system can help us in some of those encounters. It's changing now where you don't have to go to the office for certain deals.
Right.
We have a advanced IT system, so let's look to see how how we can use our IT system that will help us with our efficiencies and will also help with care. I mean, we've invested the dollars, so that might be a way, as we are looking at what we need to do, make sure we look at that.
I agree.
Because as we do that, that might impact some of the other things that we're talking about that we need.
Yes, ma'am. Dorothy, it ties right back to Warren's tell them. Go ahead, DT, I'm sorry.
I know we're at the crossroad for transformation, so I know it's a lot of work, but we don't have to do it right away, but we need to start looking at as a system rather than a hospital, because all of our financial number and everything else shows revenue coming in from the hospital. We're managing lives now going forward. Otherwise, we can never build a hospital the size that we want to be. So some of the key important indicators that, the less people we put in bed, the better we are. But we want to make sure that we don't put them in bed. That doesn't mean activity outside at the doctor's office are not being met. Because that's the only indicator to see if we can find a way that we can improve quality and all that stuff. So the cost of care is important for us to look at, because we can, and the quality of it. But also, I think we need to start looking at, the standard of care and then the practice patterns also as well. So that as you use more information, you can look at, say, before surgery. How long does it take for the patient to be diagnosed and be a primary care physician before, how many of them end up in surgery? How many of them end up just taking some prescription and go home okay? Some have to go to rehab and all that stuff before surgery. I think those will help us moving forward with the risk and all that stuff. If we don't do that, and if we don't look at the, from a system standpoint, then we may inadvertently not providing care, because the less care we provide, the more money we make. So I just want to be cautious how we balance things out and we shift them on. because we are acting, we have the funds that we use. A lot of it is taxpayer dollar. So the less we deliver care, the more money we want to make. I don't want that to be the case. So there's some balance that we need to do. It will take time, but let's move it at the same time we plan. Because I don't think we can change the format today, but let's shoot for a future date so that we can start the
Good point.
transformation.
Just an observation, and think about this for staff. We have, most of our committee meetings are on the 26th of July. We had not had a planning committee on the agenda for that day. What if we considered having a planning workshop on that day when the whole board's already here? We might be able to, I mean, we've got, Dorothy, your committee and Steve's committee are both already meeting that day.
I canceled
one of
mine.
them's
We
been
did not
canceled.
have enough
Oh, is that
agenda,
right?
so it's open for you to do a planning.
But
Yes.
we might, because, I mean, half of us are gonna be here, probably all of us, are gonna
Right.
be here at part of that day anyway. Robert, is that might work? Because if we've got the 20th, when this is the deadline for the
I
commissioners.
agree.
We don't have a lot of time.
No, we don't. And Dorothy, I got your email
Right.
canceling that one, so that'd
Yeah,
be,
let's,
that'd be a perfect
let's
delay.
take, yeah,
Let's
and
lay
we'll
that
get
right
out,
into
let
there.
me check schedules of everybody
back to everybody.
and make sure and see where, quorums lie and all that.
Good.
And that's all fine. We have to be sensitive to the time frame. So whenever it is, 26th,
Yeah.
24th, 23rd, that's a
We need to
smart
give
thing.
your staff time to compile it once we've
Give
met.
us those recommendations.
To be able to put it in
Sure,
format.
and again, still be very sensitive to the court. Yeah, we can definitely look at those time options.
Well, that would be
for
an
sure.
option at least, because everybody's
Okay.
already here.
I think
Yeah,
that's a good
helpful.
point. And
Very
Dorothy, yeah,
helpful.
I saw your email.
Thanks.
Not
Yes, Warren.
scheduling there. That's the 26th and 27th is the healthcare conference at the Gaylord too. So a couple of us like to go to that.
That's right, this is compliance.
It's close.
It is close. Yeah, but
I drive very far.
that's why I like to attend it, because it's a great resource and great opportunity to learn what we're supposed to be doing better here. So if we could avoid the 26th and 27th, that'd be great.
Robert, why don't we
24th
do
seems
this?
to be okay.
Started on the
Well, one thing
Yeah,
I've
let's
learned
get back.
in my career that you don't debate until you talk to everybody is logos and schedule. So I really don't want to debate that. So what we'll do is we'll
Let's get
look
back, yes.
at that and we'll look at everybody's schedule and
As
try
long
to
as it's
figure out how
not,
to do it.
Warren can't make it that day, so we're gonna do it that day.
That was the plan. Now, Warren, Warren, you're always giving me, no, we want you there, Warren. We would like to have you there, Warren, but the reality is this, why don't you have? if
I
you
will.
would,
We'll
Suzanne,
go through and
let's-
we'll
you
check. We'll
with
make
your
phone calls.
staff, and let's check, there's only 11 of us. So, and I say this many times, and I'll kind of end this piece on this. We want all the input. The Commissioners Court has asked for that. And I think it was Trent's comment earlier that there's 3 chairmen sitting, past chairmen sitting on this board. This issue's been 31 years since there hasn't been a bond package. We need to do everything we can, and I've said this before, appreciate all the time y'all give to this organization, but I think we're gonna have to, whether it's the 24th, the 26th, whenever it is, I think we're gonna have to really get together and finalize some of this stuff, because we have a Commissioners Court asking, and it's their decision, but at the end of the day, we need to get the information back to them as quick as possible. So, Robert, if you would make that a priority, we'll get with everyone on schedules.
The only thing, Mr. Chairman, I would correct you on is when you made the statement, there's only 11 of us. Because there is only 11, but when you take these 11 people and the schedules that y'all have, it's like 7,000
Well,
people.
we'll,
We will definitely make that work. And I want to have the opportunity also, and I appreciate that suggestion, Mr. Pat, I want to consult with GK as well to kind of know when court meetings are and those kind of things. So we'll make this work.
yeah, because we need to come to this next meeting, and again, we've been very open, we know what we kind of need to do, or we've been asked to do, but we're getting to that point in time where we need to finalize and get whatever those recommendations, whatever they are, we need to get them back to the court so they can make that decision. So again, I'm not trying to be political when I say this. I appreciate, there's been a lot of people sitting in this chair for me. We're here sometimes, we don't always agree on everything, but I think we agree on what we're due for this hospital in this district. So thank y'all for the time you've given, but you're gonna give a whole lot more here in probably the next 30 days. So thank you for what you have done, and get ready, because here we go again. But if there's nothing else here, Robert.
Yeah,
I
Mr.
would
Chairman,
go-
that's all I have for my
Okay.
report.
Any other questions? Warren, go ahead.
Yeah, and I don't know when we should address this or not, but there was an extremely negative story that broke yesterday in the media about JPS, and I think that, certainly, I think a few of us have heard of it, and I know it's only one day out, but do we have a public statement to address that matter?
Tell me the media.
It is the direct action report that was discussed, talking about accusing us of having a doctor that's pulling in the plug early.
Okay. The challenge with that is any community group, and that's why I want to look at media or what media means. Any public group that makes a statement is challenging for us to respond back to each one of those. And I think we've got to go through the process, as we have here gone through the process and kept you as a board informed of what those situations are and what the situation is in that particular case. The comments, and I have not read all those comments may be based on an individual's opinion or a group of people's opinions. I don't know. I know that process went through a vetting process here at JPS. I don't know if you as a board would want the prerogative of this administration or you as board members responding to any community comment that is made on a social media type situation or anything else.
Yeah, I'm certainly not saying that this board should have a practice, or the hospital should have a practice of responding to every accusation that's made. But I do think when somebody makes an accusation or a comment that seems to at least have some substantial allegations and that appear to have some legs to them, that we ought to have a practice of responding to those. And this seemed to be one of those things. Again, not every little thing, but this, I guess we'll probably talk about it in closed maybe, but this seemed to warrant a public statement in response. If somebody wrote this about my law firm, I would respond to it, and I would have a public statement, and I would have it out pretty fast. So it's not on the agenda, so it's your report. I just thought I'd ask.
Well, it's not on the agenda because you can't react that fast to put those items on the agenda.
Right.
But appreciate your opinion.
Yeah.
I'd like to add on to Warren's. I get information sent to me. It is not comfortable to have this type of information coming to me, and I know I wasn't here for the May board meeting, so maybe there was some discussion on it. But there appears to be some validity for me to know a little bit more about what this article is saying. And we are a public entity. So if there is something that you can't share with me in open, you should share it with the board in closed. I mean, I do think that article bothers me drastically.
Any other comments? Okay, then we move along to item number 7 on the agenda. And I guess I'd ask Dr. Hurd to come up and give us an update from the executive medical staff. Cheryl.
Dr. Schrader has decided that he gets the luxury of taking a vacation, so he took one. Dr. Hurd is our vice chair of the medical staff, and as you well know, Dr. Hurd, this is the just sort of an update of what's happening with the medical staff, and then, of course, you will come back during close and we'll go through privileges as well, but we appreciate that. So it's all yours, my dear.
Okay, great. So is this the point where we talk about the credentialing activity, or that's close? Okay, I
No.
apologize. Update from the medical executive staff. Well, actually, what was really encouraging is on June the 29th, there was a Leadership Development Institute that JPS puts on for a lot of their staff members, and we were really excited that several medical staff members also attended that. So we're seeing more and more physician engagement, providers who are wanting to take on more responsibility and really help collaborate better with patient care, improve the quality that we're already working on to improve. And so that was really exciting in that regards. We're also looking at some new privileging for for moderate sedation, but we haven't formalized that actual card yet. So that's pretty much the only update I have for the medical staff.
I do like you.
Any questions for Dr. Hurd? There being none, I'd also, under that item number A, approval of the moderate sedation clinical privilege. Dr. Hurd, would you care to cover that also?
Yes, that's what I mentioned before. We are actually collaborating with more than one department to perform moderate sedation, working on privileging, a collective privileging form. And I don't believe we have it quite finalized yet through the credentialing committee, but we are going to be bringing that forward.
Do we need approval on that policy that shows on that?
Not finished yet.
It was in the package and it was attached for everybody.
Is it in the package?
Yes, it was.
I don't have the package, I apologize.
The board had it previously. I think there's a recommendation for approval of this.
It's page 12 in our.
Yes.
But if she's saying that it's not quite finished, then
Oh, I apologize, Mr. Bose. Dr. Schrader was working on things, and I'm subbing in for him, so he may have had everything finalized. I apologize if I misspoke.
Dorothy, I want clarification. I don't want you voting on something if you don't think it's finished. It was my understanding it is an agenda item, and it was given to the board
Yeah, I
as an
believe,
approval,
let me.
but I certainly want clarification. I don't
Mr.
want
Roll,
anybody-
let me,
That's fine. I don't want anybody voting on anything if we think there's, Dr. Hurd, thank you very much. We'll bring that back.
I apologize
Don't worry about
for
it. Thank you. You're
misspeaking.
fine. Thank you very much.
You're fine.
Thank you for setting in. Is there any other questions at this time? If not, thank you very much, and we'll talk to you about privileges and close. Thank you very much. Obviously, the next item is number 8 on the agenda, the acclaimed physician group. And if I could have Dr. Hutchberg, Michael, if you and Mrs. Rachel, Diane, if y'all would come up. Thank y'all very much. Good afternoon.
Michael is in week 7 here, so we have worked together on this report, and I'll deliver it, and next month he'll be ready to fly solo.
Right, I'm super excited.
There's not a lot of new news this month in the recruiting arena for acclaimed providers. We continue to recruit heavily for neurology, ENT, and dermatology. We have onboarded a part-time dermatologist from the community who started this week, and we have another locum starting in the August-September timeframe as soon as privileging is completed. In neurology, we'll have an additional locums coverage beginning in September, and we continue to interview candidates. We just have had a hard time really matching culture and clinical skills. We're using outside recruiting firms to assist in these hires, and we're looking at community partnerships for dermatology and ENT in particular for the long term, and we'll keep you updated on those conversations as they move forward. This month, we are onboarding 15 new providers. Of note, we have a new pulmonologist, a new surgery resident program director, Dr. Olivas, will start later this month. A new plastic surgeon, Dr. Stephen Mapula, will join us. Palliative care physician, additional, which we've talked about, expanding that service. 2 of those physicians are rejoining Acclaim. They left, they were here at JPS previously, went off and have come back to Acclaim now, so we're excited to have them back. In addition, we're retaining one of our OB-GYN residents who also happens to have had the highest patient satisfaction scores for many months this year. Dr. Brett Westbrook will be joining us this month. We'll stay on. So we're always happy when we retain our residents as full-time providers at JPS and Acclaim. You will see over the next couple of months the providers working in the Tarrant County Jail will transition from UNT to Acclaim in the end of August. JPS and Acclaim have had that contract for a while, but those providers will be move their employment to Acclaim later this year. And all those contracts are signed and they're ready to come right before as the fiscal year begins. As we assess our patient care needs for the coming year, we are looking to expand urology. As you know, we've brought on a new urology group last year. They've had a year to assess the landscape and environment here, and they're going to be asking for some additional practitioner coverage so that we can continue to decrease wait times for our patients. Also, maternal fetal medicine services. We brought on a new group 2 years ago this fall. They also have come back to us. They've been working really, really hard, gone way above and beyond, and are asking for some additional coverage for physicians as well. So those are probably the 2 big services that we're looking to expand a bit to take care of our patients and the needs of our patients better. With Michael's coming on board, and as we look at the national healthcare changes, we have extended an offer to a director of CMS innovation and ACO development. That's not a position, that's a staff member. As we begin to work looking at our managed care contracts and seeing where our opportunities are to increase reimbursement and payment based on quality metrics and eventually ACO as we go forward. We are also developing lead APP position. You've heard me talk a little bit. We have a large number of APPs. They are decentralized in all their specialties, but they are hoping to have leadership. So we'll be interviewing and bringing on a lead APP who will have clinical practice, but will also have some administrative time to help with that large group of providers. We have also posted a couple of leadership positions that will be part clinical and part administrative. An executive director of inpatient programming and innovation to help us bring all of the patient care across the inpatient areas together on the claim side, and on the and an executive medical director of population health. So more to come on that. Those interviews begin next week. We've had quite an interest, both internally and some external, for those positions. So more to come on that as we go. You do not have any contracts on the consent agenda this month related to PMSAs, although as the fall comes on, you will see more of those come forward as the groups transition to a claim. And that's our report. Yes, sir.
One thing, that under the consent agenda, but I think it belongs with them, is they now have 2 new board members of the acclaimed physician board. One is Dr. Jocelyn Z., who's an internist here, and Dr. Stephanie Carson Henderson, that I believe works in the OBGYN department.
That's correct.
So
She's an OB-GYN consultant.
that'll be under the consent agenda, but
They are joining the board.
That's who the individual, right? Chuck?
That is correct.
Okay.
And does everyone
And the
know
physician
Chuck
board.
serves as
Yeah, right.
chair of the board and claim executive?
Yes.
Thank you very much.
Just for, have a couple of questions.
Yes, ma'am.
On the last group you mentioned that was going to be increasing their numbers, are we having an increase in deliveries here?
Not for, they're just adding, they're replacing OB-GYN. It's a new physician to replace, it's a backfill.
It says just a backfill, so we aren't adding.
Yes, ma'am. We're not adding for OB-GYN.
Okay.
Maternal fetal medicine services are only touching for consult, actually, a 10%, about 10% of our patients, and we believe there's probably a need for them to touch more of our complex and high-risk patients here.
Okay, that's the
They
contract.
don't deliver, right?
Right, I know they don't
They-
deliver,
yeah, they take
but
care
they were the one afterwards, and so I was just trying to see if we had a larger number of deliveries that they were, they just never had enough, because I remember that contract,
That
it
is
was
correct.
pretty.
You remember, we didn't have enough coverage. We expanded coverage 2 years ago, and we continue to have a need for their services here at JPS
Okay,
with our patient population,
All right.
which is,
and on your urology that you're increasing, what's our waiting time? Because I'm trying to figure, you don't have to tell me, you can send it to me.
I can
but-
send it to you.
okay.
They've continued to work on it,
Yeah.
and I'll actually send you their accomplishments for the year. They just put together a nice email to us about their accomplishments. They've been working really hard. They had told us initially it would take about 9 months to do a full assessment of the needs here,
Okay,
and we're at that place, and so they've come back and said they want to bring a little more specialty care.
yeah, and I would think when you do that, you would tell me, this is where we are, and this is, if with this is where we plan on going to.
I'll put that,
Okay,
I'll
all
put
right.
that for you.
Thanks.
we will be doing that for every service. At the acclaimed executive committee, I think that's one of the things that we ought to just briefly touch on.
Yes, come on.
Right.
Okay.
Yes,
Good,
And we can bring it to the full board.
all right.
yes, sir.
Quick question. Do you know when you're looking at the, you mentioned recruiting for the ACO and all that stuff. Do you know when is that? You're planning to join ACO and all that stuff?
Well, part of that work, and we'll let Dr. Hochberg answer this. Use this one.
God is looking down on us disfavorably.
Great. Now you can see why it's taking me 7 weeks to, be able to give this report. I can't figure out where to sit for the mic. So with regards to your question on the CMS Innovations position, so the actual title of the position is CMS Innovations in Value-Based Care, to really look at those areas in which we're able to begin to better manage patients on the outpatient side, and obviously how it looks across the stratum of healthcare on the inpatient side as well. There is no definitive timetable related to specifically ACO. I think our first stage is begin to just look at our employees and see if we can develop a virtual ACO surrounding our employees. Once we begin to better understand how we manage data, how we do care coordination on those elements there, then I think we can begin to model that to actually develop a full-blown ACO. So the timeline is roughly over the next couple of months to, get this person on board, get some infrastructure in place, get a better understanding, and then begin to look at either a next-gen or MSSP ACO. How do we become certified in that? But before we ever go down that road, we need to critically know that we're able to manage the data, understand utilization patterns, control for provider variation, all those elements that will go in there to make us be successful on an actual ACO strategy.
And you intend to do it less risk in the beginning and then more and more risk down the road into full risk type thing, or?
I think it's ultimately going to depend upon, the global strategy that organizationally, that we wish to go down. But certainly when you look at ACOs and value-based care, it is potentially about looking at risk and how you manage risk and negotiating those types of contracts. But I don't want to get ahead of what a global strategy may be.
May I make a suggestion?
Absolutely, of course.
When you negotiate with those entities, there's two things that most ACO fail to hit the number. One is the mental health, which they never give it to you, the number. And then also the other one is going to be the market share and the adjustment. Because with those numbers, if you don't know, and they add at the bottom, at the end of it, what you may feel like it's going to be the big bonus may disappear right in front of your eye. And those are the numbers that you have to negotiate right up front before. Because once they lock that down, they won't give you that number.
Absolutely.
And it's a game that they play. And it's almost like, if you want the risk, I'll unload the risk, I know you're gonna lose.
Yeah.
Type of thing. So if you need some more information, we'll be glad to provide it to you. But that's the right way to do it. I will really commend you guys start looking at it.
Yeah, absolutely. Again, I think we've got plenty of time to figure out all those elements. The individual that we've put an offer out to has developed ACOs in other organizations, so she's definitely got a certain degree of skill set. But certainly, that's all of it needs to align with exactly the direction that JPS wants to move towards when it comes to a risk assessment.
I'm pretty sure you guys are headed right direction. Just the insurance playing game.
That's exactly right. That's where healthcare is going, and so we just want to be on the cutting edge of that to be prepared should that pathway come our way.
Excellent. Thank you.
And that's one of the reasons he's here. One of the many.
Any other questions for claim for Mike or Diana? Thank y'all so very much. And
Thank
we're
you.
looking forward to your 8th week, your 9th week, and keep right on going,
Yeah,
Michael.
every time I'm here,
Yeah.
I'm just going to continue to
That's
announce
right.
that.
Thank you very much. We'll move along to item number 9 on the agenda, which is our committee reports, and the first one up is Dr. Weber on quality.
Thank you. There are 5 district policies that are on the consent agenda. There's safety, medication diversion prevention, house staff order policy, archiving lab services policy, and approval of an informed consent policy. As part of that discussion, we're trying to get consistency when we talk about interns and residents. So we'll be referring to both as house staff on any future policies to try and so we have consistency when we talk about them. Another thing, this is for the community. One of the things that's been discussed in many, many organizations is the concept of a highly functioning board. God is talking. Danger, danger. And one of the things that has been suggested is having community members on boards. And I'd like to say that for over a year, we've had at least 2 community members at every quality committee. And they give their input and they hear what our input is. And I think it's been very valuable for both of us. One of the things was it's called the AMI program, but it's an acute myocardial infarction program. Essentially, it's a heart attack program that was surveyed and approved. Another good one for us. And the last part of the quality committee was Laura presented the patient, employee, physician sort of package. And it's looking better and better and better. So, thank you. And that's it for me.
Any questions for Paul? No, Chuck, thank you very much. Next will be finance, which is meeting June 28th. Steve, I'll turn it over to you.
Yes, sir. Thank you, Mr. Chairman. We had a meeting on June 28th where we reviewed the May financials. We also forwarded on for the board's consideration a handful of contracts which are on consent today, and I recommend their approval when the time comes.
Thank you very much. Sharon, would you like to come up and give our financial summary? Trent got ahead of me. I was going to also congratulate for our new bond ratings, but as usual, Trent's out ahead of me. So congratulations on the double A, stable condition, strong position.
Okay. So for May, I covered this in much more detail at finance, but you can see where we had a very close budget month, so we were right on our plan. The medical center had strong inpatient volumes that were offset slightly with weaker outpatient volumes. And the medical center ended the month at an operating margin of $160,000 compared to a budget of $115,000. Looking at a claim, they were right on budget as well. So the total net income for the month was $227,000 compared to a budgeted loss of $367,000. From a bottom line standpoint, we're right at $209,000 for the months through May, compared to a budgeted net income of about $650,000. So over the next 4 months, we'll be working towards narrowing that gap. Any questions?
Any questions for Sharon or Steve? Steve, anything else you'd like to add? Anything else you'd like to add? All right, and thank y'all very much. I'd like to have a motion, if we would, for the acceptance of the financial report as given. I think it comes, I have a motion from Steve and a second by Mr. Wynn. All those in favor say aye. Aye. Thank you very much, which takes us down to the Governance Committee. And Roger, all yours.
It's your very own Blue Ribbon Governance Committee. That's a correction.
All right.
We met on Thursday, the 28th, with lively discussion as always. Ron provided an ERM update, as well as we had David Mendenhall provided us with a very in-depth, very eye-opening, we understand why David doesn't sleep, presentation on cybersecurity. We also got to meet Yolanda Rich, the new compliance director. So we have no items on consent today, but that's your Blue Ribbon Governance Committee report.
I will take that as your report. Thank you so very much. Before we go to item number 10, it's not here, I just may ask, I know we serve again as indicated in a lot of places. DT actually represents us as a liaison between this board and the JPS Foundation. I know they had a board meeting this week. DT, is anything particular that you want to just mention that happened during that meeting?
No, we just had the pleasure to have the judge there, and he was kind enough to explain to us about the Blue Ribbon and
Good.
the upcoming.
Super. Well,
Super.
Thank you so much for your service to that. Item number 10 is, I guess, Corey, I'll turn that over to you. Is consider approval of the policies or anything you need to update from a legal matter.
This is approval for policy RI 2200, which is a new policy for addressing do not resuscitate orders issued in a healthcare facility or hospital. This is to implement Senate Bill 11, which added sections to the Texas Advanced Directives Act. And those sections define and set parameters for in-hospital DNR orders. And our policy and the associated procedure just track that language in the statute.
That was provided previously for y'all's review, and any questions, if y'all have any questions, I'll address them to legal counsel. If not, I'd entertain a motion
Take a
for
motion
approval.
to approve.
Have a motion for approval.
Second.
Have a second by Dr. Hire. All those in favor say aye. Aye. Opposed, no. Thank y'all very much. Which brings us down to, we mentioned the consent agenda several times, brings us down to item number 11. If there's any questions or any issues concerning any of that, if not, several of it's been discussed. If not, I would certainly entertain a motion for approval of the consent agenda. I have a motion by Mr. Montgomery, I have a second by Mr. Bose. All those in favor say aye. Opposed, no. Thank you very much. Takes us back down to, Corey, I'll ask you again, is there any legal matters that need to come before the board?
Just a report of contracts negotiated on behalf of Tarrant County Hospital District that are under 200. There were 34 of those, and I think they're posted to the portal.
Okay. All righty. Which brings us down to, I guess, is there, other than privileges, is there any other items that we would indicate for close? Yes, Ralph.
Not before close.
Okay.
I have a question on when an item is submitted, maybe, I think, to the Finance Committee, and we're asking for non-competitive bidding. Could I see the process of how that's done? So I know that those agencies may have a particular expertise that others may not have. So I guess my question is, is there a list of those agencies that we can go to, or do we advertise even though it's not non-competitive bidding?
Right.
So
And I like that question. Maybe something we do at the next finance committee is talk about procurement and those processes, because I can't
Okay.
really articulate them to you either. And it might be good for us all to kind of get our heads around that.
Okay.
So we'll make sure it's on the next finance agenda.
Sure, okay.
Yeah, and Ralph, I think your point's well made, and that's why I've reached out to you after the last finance meeting, because I think there were 3 on this, and I was in finance, and so it's.
More of those lately,
Yeah, we've had
right.
several of those, and certainly in view of the fact there's a bond potential package out there. I think your first part of your question was, can you have access? I'm telling you, as chair of the board, yes, you have access to anything you want. But second of all, I think the process is really, what are we doing going forward? And I know we're reaching out to several other organizations in the community, reaching out to them, knowing that, we're getting a lot of contacts. I know Scott Rule gets tired of me giving his name out, but sometimes I'm in the community, I hear this, well, how do we find out what's going to happen at JPS, and how do we get, I say, call Scott Rule. There's a process, but I don't handle that. So I'd advise the board that's the best thing. But back to your question, Ralph, I think it's probably a good timing to really get that process done.
Very good timing.
Good deal. Anything else before we go to close? I don't think we'll be in close very long, but we never know. And so I will say, yes, Rex,
I
for
have
you.
one thing I'd like to point out, how fortunate we are to have a CEO who had 14 years' experience in the legislature, who knows how to deal with politicians.
Thank you. Just because I was there for 14 years doesn't mean I know anything about politicians.
We're going to put those two together.
Thank you for your kindness.
Yeah. Based on that point, we will recess at 2:35 for about 10 minutes, and we'll come back and do close. Thank y'all very much.
Yeah, it's like the movies.
Thank you very much. I would now like to reconvene in open session at 4:48. And again, we have before us.
3:48.
Oh, excuse me, 3:48. It's been a long afternoon. And we would discuss privileges, and Dr. Hurt, I would call on you for presenting those.
No, I recommend the approval of the appointments and reappointments as presented by the medical staff.
I have a motion, I have a second by Reverend Emerson. All those in favor say aye. Aye. Opposed, no. Is there any other business to come before the board today? There being none, thank y'all very much for your attendance. We stand adjourned. Thank you.